Greetings, everyone. This is Eric Glazer, and welcome back to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, at hospital systems, and other healthcare-related organizations around the land. Our goal is to identify as many of these bright spots as possible so that you could determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not subscribed to the podcast, I highly encourage you to do so. You get access to incredible wealth of information from organizations and leaders across the country. So stop what you're doing right now. Go to your favorite podcast app, type in Bright Spots in Healthcare, and please subscribe. Really great topic today. I know it's important to everyone. It's an ongoing challenge for us in the industry, and that's how to create more bright spots in post-acute and home care. We have an incredible panel that I'm going to introduce to you in just a moment. Our partner in crime and sponsor for today's episode is an organization called Wellsky. If you haven't heard about them, they empower healthcare and community care providers to deliver patient-centered, data-driven, and highly coordinated care. Their mission is to support providers, community organizations, and payers with incredible solutions that improve outcomes through all kinds of efficiencies, intelligence, and connections. And I'm going to tell you a little bit more about them later on during the episode. But if you want to check them out right now, you could go to Wellsky, W-E-L-L, Sky, S-K-Y, one word, .com. So really appreciate everyone being here. We're going to put bios for our panelists into the chat so that we could save ourselves some time. And if you were listening on the podcast, we'll certainly put it into the show description, and you'll be able to gain a little bit of insight into the expertise you're about to all benefit from today. I will, let me just quickly mention who they are, and then we'll bring in our first question and our first guest. First, Andy Eilert is the president of the emerging markets for the aforementioned Wellsky. We have Dr. Susan Beane. She's the executive medical director at Health System Transformation at Healthfirst in New York City. And we have Dr. Robert Schreiber, vice president and national medical director at myPlace Health. So thank you all for being here. Really appreciate it. I'm looking forward to this conversation, especially after meeting with all of you individually. I know we're going to have some really interesting stories. So I want to actually start with, let's say, sharing some case studies and some stories for everyone listening and watching us right now. And I'll start with you, Susan. How are you at Healthfirst building your provider partnerships beyond the traditional transition of care programs? Let's set it up that way.
Well, thank you so much for having me. And I really appreciate my two colleagues who are on this podcast, because a lot of what they do really jives with the way that we think about things at Healthfirst. So as a managed care company, we are often the connector. And we understand that it's our role to be sure that continuity and coordination happens as people are transitioning from one setting to the other. Emergency department and inpatient care are examples of that. And a big player in that whole body of work are our providers. And at Healthfirst, we do have teams that work closely with our providers to enable joint care coordination efforts. And we do this through various kinds of outreach, especially from our care managers who are often the front line in terms of facilitating these transitions.
Could you speak a little bit to sort of the components of what you're doing, whether it be how what are some of the key components that make up that transition of care program at a high level?
In our marketplace, at least in New York, we have providers who are really interested in being in close connection with their patients at all times. And therefore, I do believe that innovation can come from all quarters. And I know you'll hear more about that, especially from my colleagues. But to the extent possible, if our members are transitioning from one center to the other setting to the other, if we can supply alerts or information about those transitions in addition to what providers are already receiving through other platforms, we will do so. And our care management teams are very geared into ensuring that they themselves outreach to providers to activate any kinds of transition programs that they have in place in the community.
Great. And, Andy Eilert is the president of emerging markets at WellSky. Andy, can you provide us an example maybe of how a health plan is approaching this whole challenge of reducing readmissions, especially among like what I would say, the higher risk folks, let's say in Medicare Advantage?
Yeah, you bet. And before I get started, can you hear me okay?
Yeah, we can.
Yeah. It's a pleasure to be here with my colleagues, and I have a ton of passion around this, as they do, as well as we were speaking before this. So I appreciate the opportunity to sort of evangelize this space. I will tell you a pretty simple but highly impactful story. When we were early in I've been here at WellSky for 3 years, working on setting up a payer business. As you mentioned, WellSky is predominantly focused on the provider side historically, technology in the acute care setting, post-acute care, and home setting. So having the ability to set up these solutions for payers has been a real privilege. This particular example I wanted to talk about is National MA Plan. They had a readmission problem. It was again an early iteration of work we were doing in our model today, which I'll spend more time talking about later. They had invested, this particular payer had a lot of resources and a lot of capital. They invested significantly around the post-acute care space in the SNF space. Their biggest problem was they lost track of and the ability to influence what happens to one of their members when they go home. And so the result was pretty significant line item on their cost structure around avoidable readmissions, and specifically within the first 72 hours or so. I think in those of us that play in the Medicare Advantage space understand as well that this is exacerbated additionally by the high rejection rates of home health agencies for Medicare Advantage patients. There are structural issues, there are incentive issues there, which I'll probably spend some time on later, but just know that was also creating a problem, created delays in starts of care, and the quality of the agencies that were accepting those referrals was at times lower than ideal. So the solution in this particular example is their care navigators needed visibility via technology to what was happening to the patient when they lost sight of them and they went into the home setting. The ability to, in near real time, schedule a home health nurse that had accepted the job of going in and doing a transitional care visit and assessment of the environmental factors, the clinical factors, the social factors that the member was dealing with in that home setting in their natural habitat. And then to seamlessly communicate that information back to the payers' care managers, they called them care navigators. This was the solution that they were looking for, and the one that was delivered in, again, near real time. The result in that, and again, that early example was that for the patient population we were engaging around, the payer was able to achieve a 38% reduction in readmissions just by having that real-time visibility, adequate supply of nurses to engage, and the ability to connect back quickly so that the engagement could happen and the impacts could happen faster. So that's the story. Eric.
I'm always good for like every third show I do that. So could you talk a little bit about the actual impact from a number standpoint? Can you share what was the ROI, if you will? You're on mute, Andy. We're
doing really well, Eric. We're doing well. The ROI was significant. I can't, out of confidentiality, talk about the actual dollars, but let's just say it was north of a 7-8 to 1 sort of return on investment. And even though the cost of a human being going into the home is expensive, especially on a one-off basis, because they would desire an ongoing engagement from a home health nurse perspective, we were able in our model to pay them appropriately because of the result that we were able to generate for the payer. So it gets back to having the right funding model that affords the right level of care, and paying and aligning incentives to those providers that are participating with you.
And the key components that made this particular example so successful and so effective was connecting the data to those available home health providers.
It was a few things. So think about it as bridging, crossing the chasm, right? You've got care managers trying to do a good job, lose track and don't have visibility to what happens in the home. You have home health providers that go into the home that are there to do a very specific job on behalf of this payer. So a couple things. Number one, connecting the care coordination technology used by the payer to the EMR that was used by the home health agency, both provided by Wellsky in this example, and connecting those things. So data interoperability was not the burden, was not the barrier. The ability to pre-program the assessment that was co-developed between, in this case, the payer and Wellsky into the workflow of the provider. So they went in there, they knew their job, they performed their job for that one-off visit. There would be no further engagement from that provider in that case. But the result was then immediately visible to the care coordinator at the payer, who could then intervene. The only other thing I would say is part of that engagement, the other third leg of the stool was engaging the primary care provider as well, making them aware of what those observations were, kind of a 360 view of the patient and their natural habitat.
Got it. Incidentally, folks, if you're watching us live right now and you want to help me co-moderate, you could throw some questions into the Q&A module, which is that icon roughly, depending on your look on Zoom, 3 from the right. And we will be monitoring that, and we'll try to integrate your questions into the flow of today's conversation, make my job a little easier. Also, speaking of my job, we are going to be asking you for some feedback at 45 minutes past the hour, just to give us some guidance on the type of programming you want to hear from us on next year, and just help us get a little better each and every session. So for those of you to take the 2 or 3 minutes to complete that survey, it's a Survey Monkey, and it's almost all multiple choice. We'll be emailing that to you. And then, Jess, if you don't mind, let's take my notes. I'm typing in here to Google Drive, and we could throw anyone that completes the survey for us a copy of my notes, so they have my unabridged. Maybe we'll fix some of the typos, but not all of them. Notes on today's episode as a thank you. So thank you in advance for that feedback. I want to bring in Dr. Robert Schreiber. He is the Vice President, National Medical Director at myPlace Health. Dr. Schreiber, at a high level, first of all, who's myPlace? And then how are you handling transition of care on your end?
Sure, Eric. And again, I'm also grateful to be part of this discussion and try to add some useful information to the audience here. So myPlace Health is a program that was developed by the SCAN Health Plan and Commonwealth Care Alliance to provide care for frail, complex older adults, specifically dual eligibles and Medicaid only. And the way we're doing this is by taking the PACE model, the Program for All-Inclusive Care, which I'll explain in a second, to really try to scale it. And the way we're doing this is to really develop approaches and prototypes and learning and development training modules so that we do things using evidence-based approaches, but most importantly, focusing on personalized goals of the individual, what really matters most to them and what do they want to achieve. The PACE model has been around since the 1970s. It's in 32 states and DC, as well as having about 80,000 people in it. So it's a very small program, but it is expanding very fast. And just an aside, the Congress, House of Representatives, is voting today on the Elizabeth Dole Home Care Act that will give access to all veterans to PACE programs. in their communities if they exist. So it's very exciting. So it is expanded. It's for people 55 years and older who are nursing home eligible. They have to, like I said, be either dual or Medicaid only, and they have to live in a defined geographic zip code about within an hour of the PACE center. We are both a provider, a clinic, as well as a payer. So we're totally at risk. It's total value-based care, total cost of care. And so transitions of care, as we talked about, are really critical. We are responsible, the PACE program, each one is an individual insurer, or the care of our patients, or we call them participants because they choose to participate in the program 24 hours a day, 7 days a week, 365 days a year. We are accountable. CMS holds us accountable. So we have to know where people are. So we're using ways to identify where members are that Dr. Beane brought up, the HIE. So we're really trying to get into the HIE so we can get alerted and we can be perusing that, literally all the time. We use personalized goals of care. So if their goal is not to go to the hospital, they don't want to go to a nursing home, can we find alternative methods? And we do that through innovation. And again, Dr. Beane brought this up, again, it's not only incentives, it's really what the individual wants. We know that when these individuals go to the hospital emergency department, I look at the ED as should be a front porch where you have people that come to visit and then they leave. You do not want them sucked up into the hospital because they do not do well. So we're able to do things. We can directly admit people to skilled nursing facilities and provide, hospital level care. We can provide hospital level care in the home because we can bring IV antibiotics and care teams into the home. It's all done through an interdisciplinary team. We have 11 members that were mandated to actually provide the care. And CMS requires us, we talk about finding these people. We are responsible within 48 hours of ensuring that whatever was determined in the ED or the hospital, that those recommendations either get implemented or addressed. So through regulation and through the way PACE is set up, by definition, we have to be on top of our individuals. And that is the challenge. So I guess the regulations and the mandates really are motivating us if we really want to continue doing the program.
So obviously the value I'm hearing at a high level is all about, you have no rules, right? Like you're providing care and able to provide care in a much more, I don't know what the word is, vast, aggressive, progressive.
We can be innovative. We have to follow all the Medicare rules, all the Medicaid rules. So we can't deny care. If those are indicated, we have to do it. But to your point, we can think totally out of the box and do whatever needs to be done. For example, during COVID, we turned a center, one of our health centers, adult daycare, into a skilled nursing facility in 40 days. Where was that done? That was not done anywhere other than the PACE world. So it's that type of thinking that we can do, the extraordinary.
Right. And we'll come back to that. I'd like to learn more about how that's all working, especially like skipping the going right ED to how that works. Let me shift gears. We're going to get to some of the components of what makes the programs work and maybe even get into some deeper dives with some more success stories and case studies. I first want to tell you more about Wellsky. One of the things about this show, if you're new to the show, we bring on payer and provider leaders from all over the country to share bright spots. And we always bring in a partner of ours that fits into the topic, but also supports the show. We can't do this every week without that corporate support. And we're really excited that we're working with Wellsky, especially around this topic. They are one of the larger, more innovative tech companies focusing on coordination of care. So they have this proven platform that includes software and analytics and services that you've heard a little bit from Andy that enables better outcomes across the health and community care continuum. And they're able to provide, they focus on quality, cost, and the entire experience in general, right? And it's a it's a whole gamut of whole person care as we think about that transition. And here's how they do it. They work directly with providers, the payers and the systems, and the CBOs to scale the processes and improve collaboration amongst those organizations, and then harness the power of analytics, data analytics, to connect the clinical and social care, and makes it really easy for folks to navigate individuals from the different touch points. They serve more than over 20,000 client sites, including the largest hospital systems, blood banks, cell therapy labs, home health and hospital franchises, and hospice franchises, post-acute providers, of course, government agencies, human service organizations. So 4+ decades of experience doing this. And you can, like I said, check them out at wellsky.com. But here's something cool. So their team, as I was preparing for this and getting ready for this, Andy's team, Andy probably doesn't even know this. So there's a survey that WellSky did for health plans, looking to get all of your perspectives on the biggest challenges you're encountering around post-acute care management. And so they were targeting Medicare plans with enrollments of over 115,000 members. And so lots of cool high-level takeaways, and they sent me the survey results in a summary document, and they've allowed me to send it to anyone that wants it. So if you guys want a copy of the WellSky survey, my producer, Jessica Tenzer, is going to throw up a poll, and we will send that out to you after the show. So, Andy, why not throw you back in the fire since I just plugged WellSky?
Yeah, thanks for the commercial, by the way.
How can you talk a little bit about a program and that when cases are fairly complex, I'll throw in whether it's let's call them duals or some form of dual, let's say CSNPs, for instance. When you're working where the health plan is working with a CSNP population, what are steps that they can take to gain better visibility into that individual's sort of journey from into the hospital, out of the hospital, SNF, and everywhere in between?
Yeah, you bet. And I think there are going to be a lot of parallels here to Rob and the PACE program and everything that he just described, which I love that program. I know that there's opportunities well beyond its current footprint. So congratulations, Rob. I think it's a great space. So in my world and my role, I obviously am focused on payers, and specifically, not exclusively, but mostly Medicare Advantage, duals, and spilling over into the special needs plans as well. And so the one that comes to mind, Eric, is really Zing Health. And if folks aren't familiar with Zing, it's a really strong up-and-comer in the Medicare Advantage space. We're one of the fastest growing MA plans that you maybe haven't heard of. They're in multiple markets, but they know who they are, and many of the principles they operate on are very consistent. I think, Rob, with the PACE program as well, and whole person, managing everything from social determinants to obviously clinical needs, alignment to primary care models and those that are at risk. But they've really kind of anchored on a specialization around CSNP members in diabetes and cardiovascular disease. These are complex patients, obviously. Their problem versus the earlier stage opportunity I talked about, which was on the back end of the post-acute care episode around readmission avoidance. Someone goes to the home, how do you stop them from going back in? Their problem was that they certainly had a readmission problem. They knew they had avoidable readmissions happening. They also, though, wanted to challenge their thinking and how they approach admits, the front end of that episode. Someone shows up in the ED. How do we find out in real time? How do we engage? I'll sort of come back to that. So the primary problems they were trying to solve, in addition to world peace and world hunger, are acute admissions, readmissions, and then managing the entire post-acute care episode on the cost centers being LTAC, IRF, SNF, and home health. How do we manage that morass in a more high quality, cost-effective way? So those were the problems. The solution really stems around unique technology ecosystem, the visibility at each of those settings of care, getting data visibility, connectivity, alongside, they did not have the resources to deploy, clinical resources to deploy across their high growth business, across multiple markets and so on. So they were looking also for robust outsourced clinical model, physicians, nurses, the ability to do kind of next generation authorization and evidence-based guideline management of the appropriate level of care, and then the care coordination of that end to end. And they wanted that in a wrapper, which was the first of its kind value-based model to manage an entire post-acute care episode from beginning to literally end. And so that was sort of the solution. To unpack it a little further. Imagine, Andy, CSNP member goes into the ED, the ability to identify very quickly in real time, identify if Andy is most likely a short stay in the acute care setting if he does come in, and is there an opportunity to engage? And there's a lot of nuance around what I'm saying, and those that are dealing with this today know what those nuances are. Which hospitals are they a good candidate for engagement? Are they allowing that engagement, et cetera? There are nuances. But the idea is to divert care for those that are appropriate to SNF, to home health, with the proper supports to have them not reappear in the ED. The ability to identify what's happening with Andy early in the acute care stay, such that there's proactive engagement around where he goes when he leaves, not reacting in real time to that at the back of the process. And so the ability to be more proactive and on your front foot around what's happening with Andy, let's coach you not only to the right level of care post, should they go to a SNF or home or an IRF, but also guiding to the right provider based on deep analytics that has the best outcomes for that specific condition. They're not all created equal for each condition. So that becomes very, very important. And then once in the setting of care that is appropriate with the right high quality provider, managing the duration of that care. Yes, there's opportunities to move that along as it's progressing, but not before it's progressing, the patient is progressing, so that then you effectively transition home. And I would also add the importance of having the ability to optimize the network of providers to identify those that are high performers, reward those that are high performers, align those into the network, but also to coach up others on how they can improve their performance on certain metrics. And then once again, all under the banner of a true value-based model. So the result really is Zing, in my opinion, I've been at this for a little while, is the first in the country I'm aware of deploying a true value-based model on the entire episode of care, from the time someone might show up in the ED to the time you're trying to keep them from readmitting at home. And we're happy to play a part in that.
Wow, there's a lot to unpack there. Let me see if I can do some of it for our group. This is what I wrote down. So hyper-focused on, Zing's hyper-focused on readmission and after admission, proactive, on the entire just journey of that individual. We're talking about CSNPs, so diabetes, heart failure, chronic lung disease, et cetera. We are, you mentioned the key to all this, and just keep me honest here, was using unique technology ecosystem around each setting of care. Could you tell me what you mean by unique technology ecosystem?
Yeah. So for me, it falls into a few categories. Number one, it's the ability to, and everyone has mentioned it, whether it's HIEs, you're trying to find data, you're trying to get visibility. You're trying to have visibility, and what's happening with a member at any point in time. And Wellsky has access to HIEs and so forth, but we also have the advantage of, in this case, we had the advantage of being the system of record used by various providers in their natural workflows. So, for example, 2,800 hospitals using Wellsky's technology as the discharge system of record provides us in addition to sort of ADT feeds and information, the ability to interoperate back in the workflow of that provider in a very unique, different way.
Right.
That's what I mean.
Okay,
We provide visibility, but it's bi-directional ability to engage through the technology and then through a services attached.
So I'm gonna call unique technology ecosystem three things. Includes three things: leveraging info from the HIE, which is not in of itself unique,
Right.
fit into the workflows of providers, which isn't necessarily unique, but much harder to do. So now you got both of that.
Right.
And the final thing is bi-directional information sharing. And I think all three of those combined, we can then fit into the category of unique technology ecosystem.
I think that's fair. Yeah.
You said a couple of other things. So I just want to make sure if people capture all that, and then I want to move on. You combined that with outsourced clinical model with outsourced clinicians using evidence-based medicine to get more scale. And then you called it what Zing's doing is a value-based wrapper to manage the entire post-acute experience. So right away, when I hear that, I'm imagining almost like a bundle from the time that person's admitted to whenever they get back home. They're on the hook for a certain, they're getting one number and that's it. And so
yeah, I would correct you on that one. It's not so far as a bundle. So think of it as being accountable for the costs, not in a bundle, not going to the extent of what team is the team model for Medicare or something like that, or BPCI. But being accountable from the time they're in the hospital to the time that they're home and the readmission associated with those cohorts, being accountable for the cost and the reduction of that cost. And then how we manage the alignment to the providers behind the scenes to also align to that. I can give you more examples around how we're engaging with home health agencies, how we're engaging with SNFs to align incentives inside that cost management. But there's a cost and quality accountability in the value-based model and guaranteed results back to the payer, in this case Zing. And we share and align incentives downstream with providers that are participating in the model with it. Does that make sense?
Yeah, it's great stuff. So what I wrote down is the keys to that working, and then we'll have to choosing the most appropriate facilities. To that end, right provider, right patient, right point of time, my words, but sort of what you alluded to, managing the duration of care. And then here's a couple I'd like to double click on them, maybe another episode, maybe later on today. Optimizing the network of providers and identifying and rewarding the high performers. And this is the one that caught my attention. I put it in italics. And then coaching up some of the performers who are not performing as well. And the incentive alignment. So those are some of the keys. And we could come back to them later on because there's all kinds of places we could double click on that, but I want to move on. But did I get it? Did I misrepresent anything?
I think you got it.
All right, great. So Dr. Beane, I want to bring you back in. Can we double back to like your program? You didn't mention all the components, but I know from talking to you in preparation, you mentioned one of the key things to making that program that you outlined at the beginning of today's episode is home care and house call medicine, as you call it. And that is an important part of including in the transition of care program and its success. And even though that isn't in of itself isn't necessarily unique probably to everyone listening, maybe some of the ways you implement it is. So I wanted to hear more about that.
Sure. Well, I was helped a lot by both Andy and Rob in answering that question because they pointed out some of the innovative ways that being in a person's home after transitions is important. So for Healthfirst, our main concern is that we are meeting the individual need of each member. And when I say that, it does signify the fact that not one size fits all. There has to be cultural competence, language competence, geographic concerns, and particularly, as Andy mentioned, knowing a little bit about why the person was in the hospital, and obviously, as Rob mentioned, where they should go after. So all of those components come together for us in using every tool that we can to bridge care. House calls have been, for many years, an important component of that for us. We find that sometimes providers themselves are wanting to use house calls to have visibility into a person or a patient's home. situation after discharge to promote getting them back into usual care as quickly as possible. And sometimes we at Healthfirst collaborate with certain kinds of house call providers to do the same thing. For me, the most important piece of this is understanding that, as both Andy and Rob have said, transitions happen very quickly. And often the hospitalization itself or the ED visit, all of these things are happening in quick succession. And so having frameworks available to quickly meet a person's need after their discharge is sort of the secret sauce. And to use your words, that's the bright spot. So for Healthfirst, we know that one or three things can happen. Number one, a person's discharged with a quick phone call, they're fine, they're back to usual care. Or secondly, they have to reengage in ongoing house home care, as Andy mentioned, making sure that they have some ongoing services that are going to meet their needs. But what's really interesting is that third bucket where people just need something quickly to make sure that they connect to all of the post-acute care that's been, if you will, prescribed for them. Their referrals, their prescriptions, getting back to their usual appointments in PCP care afterward. And for Healthfirst in a whole person model, we're also extremely interested in whether or not they have mental health needs, which can slow down recovery and actually lead to readmissions that could be missed. So for us, transitioning from hospital care or ED to home is really making sure that we're accessing follow-up appointments, identifying people who may be frail, have mobility issues, making sure that we don't force people into need for travel post-discharge. It's really making sure that people are able to access the immediate care that they need that often occurs outside of their home, but may be made easier by either having someone in the home, a physician, a nurse practitioner, a physician assistant, or nurse, for example, even social workers, whatever it may be. And sometimes even connecting to ongoing telehealth services as well. So people in this changing marketplace are really have complex needs. And I do believe that we have found that this house call component can be really important for some of our members as they transition home.
Okay, so the three different areas you said, or the three types of discharges, they go home, quick phone call, everything's fine. Two is a house call with ongoing services. And then the third one, which probably should be the second one in order of severity, is like a quick touch point just to help with the coordination and navigation and getting those folks back on the rails and going.
Exactly.
Do you have any? So this was a question that was submitted by one of our attendees when they registered today. Or not today, could have been leading up to today, but what are your recommendations for collaboration between primary care and the ED at admission and getting those like timely notifications to primary care?
Yes. So health plans like primary care rely on notices that usually flow through health information exchanges, or HIE. And I think from our perspective, those are direct connections that we find hospitals make with their affiliated providers, PCPs, and so on. But Andy and Rob may have a different perspective there. We do find, though, that there are occasionally special programs that hospitals will implement with their surrounding network that are based on connectivity, like Andy described and like Rob described, that sort of perpetuate what needs to happen in a particular environment, if I could give one example. So one example is a hospital system or two that uses a local community-based organization to facilitate those reconnections. And in that case, the hospital itself is connecting with the organization who then reaches out to primary care to facilitate that quick response after someone is coming out of the ED.
Got it. Love it. Great stuff. Folks, real quick, because we're not slowing down with Thanksgiving coming up. We've got 2 episodes coming up that I'd love for you to join us. If you want to come to those live recordings and you don't want to register again, we'll do it for you. We've got 2 episodes that I want to tell you about. November 21st, which is next week, how providers are maximizing hybrid care and home-based intervention. So we're going to get the provider perspective. We're going to talk a little bit more about digital technology as well. So kind of right on line with today's topic, but a little bit different. And a little bit different perspective. You're going to get some of the ACOs talking about it. And then the next week after that, on December 5th, or the week after Thanksgiving, I beg your pardon, we're going to talk about GLP-1 strategies and structuring benefits and the economic viability of just different programs to provide different results. So that'll be a fun episode as well. So if you want to register for those, we'll put that poll up and we'll get you registered for them. Robert, I want to come back to you because I want to talk about core components to the myPlace program. And I know at a high level, the program sounds a lot like other sophisticated programs in the country. And I asked you during our prep call, would you classify your program as ordinary or extraordinary? And you said, to be honest, it's extraordinary. So what are the key components to make this program so successful?
Yeah. So I think a lot of what we've heard so far from Andy and Susan are a lot of those components. I mean, we have best practice, these bright spots. If you could take just what's being done here and put together in a system, you got extraordinary care. And I think that's what PACE does. We're incentivized. So first is incentivizing all the stakeholders. And that also includes the individual, right? What matters to them? So we have an age-friendly health system approach that was developed by Institute for Healthcare Improvement and John A. Hartford Foundation out of New York City that's spreading nationally. So we have that approach where we really focus on the life goals and what matters. We meet with the emergency department providers because our people usually go to the same hospitals, but we are in contact. When they show up, we call them, we give them our phone number, we send them information. We are there to be a partner. We work with hospitalists, we work with the SNFs. We talked about a preferred SNF network. We do that. And I totally agree with Andy, trying to up the games of ones that are struggling, helping them figure out what can be done differently, how we can help. Home-based care, same type of thing with home agencies, like how do we work better together? So that's one. Alignment of the stakeholders, via education. What are we trying to do for the sickest of the sick, the most complex? If we can take care of them and they don't end up in the hospital, most providers know that these individuals, the really complex, even in the C-SNPs, that hospitals are not the best place where you can get the right care for the right person and they can get the best outcome. And oftentimes, if it can be done out of hospital or in the home, as discussed, they're going to do better. So that's really critical. And so part of the stakeholder education is also selecting SNPs, explaining to them what we need, helping them learn what we can do, that we can do different types of care inside, and again, incentivizing them to pay for those types of services. And then lastly, I think a lot of this gets, and I think this touch on about Andy, having we call it geriatric evaluation and management teams. I sort of have to laugh here, Eric, because a lot of the things that have been described we were doing in the 1990s when I was in Massachusetts, Leahy Clinic. We had a whole systematic approach of skilled nursing facility care. We actually had care coordinators, nurse practitioners stationed in SNFs, and when somebody came in, we knew exactly how long they should be there, and we managed to length the stay. We did all the things that needed to be done. We made all the communications, talked to the family, educated the individual, and we were able to move people in and out very quickly. And guess what? The readmission rates were extremely low. We're talking about 11%, 10% back in the 90s. So a lot of this is clinical model, communication, integration, and ensuring that people understand how they can all work together.
All right, let me summarize. I heard 3 things because I think that was a nice list. I love a good list. 1 is the incentive alignment. 2 is and I don't want to understate this, so tell me if I got it. Alignment of the stakeholders of the goals of the program and the patient goals. And you do this via really strong communication and education, sharing outcomes with everyone as you go to continue to get buy-in. And then the third are the geriatric evaluation and management teams, the GEM teams, and that this is not and even though this approach isn't necessarily novel, the execution and delivering on that, now that we have more knowledge, more technology, more bruises and mistakes, now we're even getting better at that, putting those three together.
And we have just to add to that, exactly right, interdisciplinary team. It's not only the primary care provider. We have a nurse, we have a social worker, we have a PT, OT, we have a nutritionist that can all go into the SNP and work with the team members and make certain that the plan of care the individual wants gets integrated and focused on.
Perfect. All right. And I can't believe how much time has already flown by. I'm enjoying this so much. So Andy, as we evolve here, technology and just our overall thinking, how are plans taking these complex patients and then enabling care managers to do a better job? Because we're touching on it, we're hearing about it at a high level. Let's get a little bit more in the weeds now and talk about any insights on how we're enabling care managers to coordinate assessments, medication reviews, social determinants, of course, and everything else.
Yeah, just a small challenge you're throwing out there. I would say, as I reflect on the two examples I gave earlier, there are some consistent themes, and I love a good list as well, by the way. So mine, it really is the magic, my opinion, the magic happens when at least three sort of things start to align. Number one, do you have visibility to what's happening with a member? And that comes in the form of data, various forms and sources for that. And there's evolution, and interoperability is helping that along, by the way. Technology, and can you make use of the data and connect this system, this side of the equation to this side of the equation? So connectivity. So visibility, I would categorize all that around what's happening with a member in as close to real time as you can get. The next is informed through that proactive engagement from teams, whoever's team that is. Is that the payer's team? Is that Rob's interdisciplinary team? Susan's team? Is it Wellsky's team operating on behalf? Whoever's team is engaging, can they be proactive using this insight in real time? Are they structured in a way to have impact? And then the last thing in our world that we're dependent upon is access to high quality post-acute care providers who are aligned in their incentive structures to participate in a way that isn't adversarial, the payers over here and the providers over there, but truly aligned to participate. So, it does get to alignment and incentive structures as probably to double click on a couple things to make it maybe more real. And the transitional care visit, the first example I gave, the technology, the care managers were able to leverage a technology that they didn't have before to give visibility and arms and legs and eyes through the network into the home setting. They didn't have that before. They deployed technology and a connected network, connected via technology and then connected via a contract that incentivized them to go in and do this work exactly the way that they wanted it done. It's almost an extension. You're bridging the gap between a payer and a provider as an extension of each other's model. So that was really what allowed that to happen in a way that happened quickly within 72 hours to avoid a poor outcome. So time was very important. Technology allowed that to happen, and the connected network of engaged providers allowed that to happen, and the efficiency of the workflows between the two allowed that. Because you need efficiency, because we're operating, as Susan said so well, I mean, these moments of care are brief, and you have to be in a position to mobilize proactively against them. On the flip side, I think what was interesting in our experience on that first one was that embedding what the payer needed to have done in the home setting, embedding it in the actual workflow of the provider made it easier, more efficient for the provider to show up and do the assessment. In this case, it was pre-wired. It was in their EMR. They knew how to operate in that. There was no learning outside of here's how to perform the assessment, which again, was broad sweeping, clinical, non-clinical, environmental, risk of fall, social determinants, and connecting out to opportunities if they don't have transportation or food insecurity or whatever it might have been. But the lesson learned there is bridging the gap between a payer system, a care management system, an EMR, which is a system of record with the provider, and bridging those things together created magic when there was a model and participants that were aligned to the outcome. It was a very simple example, but I think it's really illustrative of what can happen with more and more complex opportunities, like I discussed with Zing. And I think there, it's very similar though. It's data and insights now, not only in the home, but now in the ED, now in the hospital, now in the SNF. If you can, and by the way, the experience in the ED informs what happens in the hospital. The experience in the hospital informs what should happen downstream, and in the sharing and the cascading of that information to the next step and the next step, so that you're not reimagining the care model each step of the way.
What about what even happened before they went into the hospital, right? Even that, right?
Sure. Yeah. No, exactly. So
I got three things here. So the overall theme, if I got it, is just understanding the patient and the situation and what has happened to that individual wherever they are in the journey, pre-hospital, hospital, post-acute, all of that. And you do that through, you said, I think three things: visibility, making sure you have clear visibility and what's going on and when to enable quick engagement. You didn't specify, but I heard you in your storytelling talk about around 72 hours. So quick engagement within 3 days. So visibility that enables quick engagement. Proactive engagement, so co-developing things that could allow medication reconciliation and everything of the like. And then access to high quality providers, post-acute providers who actually are aligned based upon the payment structures. So it's almost like
yeah. And I think the proactive, just to double click on proactive, really proactive engagement model, meaning teams that are prepared to act proactively, using the insights and organizing around that, whether that's an outsourced team in the Zing example or an in-source team in the large national payer example.
Yeah.
Susan, you wanted to weigh in on, I think you want to weigh on mental health. Is that right?
Yeah, I mean, Andy, what you're speaking about in terms of these frameworks and these processes happening quickly, especially for complex people, made me remember that we are really interested in integrated solutions now, because we do know and understand that our members living with serious mental illness or depression, anxiety, which can be up to a quarter of populations nationally, plays a big role in successful transitions. And so early on, Healthfirst integrated our care management model so that our behavioral health case managers are closely aligned with our physical health case management, but we have found that needs to also extend into the home, whether it's home care, as you mentioned early on, or just overall house calls, making sure that we don't just reactivate people to their primary care, but also to, if you will, their primary behavioral health care as well. And that can contribute to successful transitions.
And just to add to that, the PACE model is integrating behavioral health, although it's been a little slow to that, but that has become really the mainstay for all the reasons you brought up, Susan. But in PACE, 60% of our population have serious mental illness. 50% are living with dementia. So by definition, it has, as Susan mentioned, it has to extend across the continuum, and all the providers, all the people that touch those individuals need support and education. Real challenge.
I want to come back to you in a second, Robert, because I have a final question for you. Susan, since you brought it up, anything about this integrated care model where you're aligning physical and mental health that is in place that seems to be sort of accelerating the success of the program? Anything?
Yes. Thank you. I want to raise two things. Number one is we are not only educating ourselves about this from the care management point of view, but we're also, when we outreach on transitions of care, mentioning this to primary care, just to make sure that they're in the loop on some of the solutions that these patients and members need. But if we have people who are appearing to us on the behavioral health side, our behavioral health transitions teams are actually being action and active on the physical health side. So especially for chronic illness, which is a major concern in terms of reducing poor outcomes, but especially readmissions. And Rob, you mentioned dementia. I mean, dementia care is Eric, that's a whole other reason for a bright spot discussion, because dementia care is really on that frontier in terms of trying to reduce readmission. So I would just say awareness first, but taking action when you find that that person is either at risk or currently actively experiencing a mental health disorder.
Yeah, I gotta tell you, folks, you're looking at the 3 newest producers I'm gonna hire for Bright Spots. I love this. Great stuff, guys. And remember, as a reminder, you've got that survey in your inbox, folks, so please take it, and we'll get you these notes. Andy, I'm gonna close out with Robert, but I'm gonna kind of throw you and your team into the wilderness here. I just think there's so much value into meeting with you or your team about not necessarily just the Wellsky platform, but more holistically, some of the things that you're seeing and what could be put in place as organizations who are listening now. So I'm going to ask anyone who's listening live right now, if they want to get introduced to Andy and his consulting team, who could maybe talk to you guys about everything they're seeing and provide you some guidance, make sense of this even more. I'm going to set up meetings for you guys. I'll make introductions on the email. I guess that's what I'll do. So I'm not going to wants to meet Andy and his team and learn more about what they're seeing out there in the market, necessarily talking about Wellsky's solution per se, but certainly what they're saying. And if you want to get an introduction, I'm happy to make those. Let's end with you, Rob. And, the program you talked about, the 3 things, all of a sudden you talked about 3 things that make the program extraordinary. I think it was incentives, alignment, and the GEM teams. Is that possible in other markets? And how do you launch a program throughout the country so that this concept, these components go viral? Are there suggestions you have to people who are listening that can apply the principles of PACE to a non-PACE program and make it better for everyone?
Yeah, so I think the answer is yes, it is actually happening. Like I said, age-friendly health systems approaches are the underlying basis of a GEM program. And I would say back in the 90s, I said that healthcare is local and regional. So I don't know if you could do it nationally. You have to do it sort of regionally and locally. But we had a health plan that actually implemented GEM with all the payer groups in Massachusetts back in the 90s, 2000. And they showed a dramatic decrease in hospitalizations, readmissions, and connectivity. So some of this is already happening. I think that there's already a nidus. It's a matter of taking best practices, many of which have been published on, and really all the bright spots and ideas that came out. How do you do that connectivity? How do you align the incentives? How do you really support the teams and the providers, SNFs, to really do the best thing for the individual? And by the way, incentivizing, what's the incentive for the individual? Who wants to be in a hospital, right? So they're actually naturally aligned to this. So the answer is yes. There is bright spots here. We can, I'd be happy to talk to people, but there are a number of things already happening.
It's great. 3 of you, thank you so much. I knew this was going to be a fun conversation. I can't believe how much more we could even be talking about, but I don't want to have us go long, as everyone knows. Want to get everyone to their 1 o'clock or 10 a.m., depending on what time zone you're on. Thank you all who are watching us live and listening on the podcast for listening today. We do not take the hour you spend with us for granted. Each and every episode, we are hoping that we put together content that enables you to use the bright spots shared during this episode to inspire your thinking and maybe enhance your organization's current approach to improving healthcare for all of us here. So we produce the show every week for you. And remember, this is your Bright Spots in Healthcare podcast. Take care, everyone. Thank you.